Good morning, everyone. Thank you for attending this month's webinar. Today, we're going to hear from Jina Huh. She's an assistant professor in the Division of Biomedical Informatics at the University of California, San Diego. Her research is using socially aggregated information to help with individuals' everyday health management. She works with online health social networks data to understand how social network exchanges can improve health. She uses qualitative methods, social analytics, and machine learning to understand, design, implement, and evaluate online health social network activities. If everyone could please mute their microphones, and you can go ahead and start, Jina.
Hi, this is Jina. Thank you so much for inviting me to this presentation opportunity. Because this might be kind of a different research area for you, please feel free to always jump in and clarify if there's any questions from you. So today I'm going to talk about closing the methodological loop in biomedical informatics research, meaning that I will discuss how I weaved various disciplines together to understand a problem in managing health. So does this remind anyone of anything? Do you know what this is? You can unmute yourself and speak up if you. So this is actually something called patterning. And what it is that it's basically using threads, very small threads, to make knots, and for you to make laces, such as this, you have to create about maybe 30 to 50 knots to generate maybe like a 50 millimeter worth of lace. So it's a very intricate job, and it requires a lot of effort and time. And this is one of my hobbies. I don't really do this anymore right now at this moment, but as I was doing this, I realized that this is very similar to the kinds of research that I'm doing. And let me kind of walk you through how that is. So coming from human-computer interaction field where we design technologies for people, there's a lot of things that I have to consider altogether. I need to think about the social aspect of it, where I need to first understand people's existing practices of how they work around the problem that I want to solve, and also the technical aspect of how can I even implement this once I understand people's practices and I have the idea for how the technology should work. Now I need to kind of solve the technical challenge of how am I really going to make it happen. And then there's the last biomedical aspect, which is how do I even know that this is actually the technology that's going to be helpful for people, and assess outcomes that can help kind of gauge the effect of this technology and how useful and helpful it's going to be. And so that sort of weaving social and technical and biomedical aspect of the research problem is how I approach my research in biomedical informatics. And as one example, I'm going to talk to you about the Infomediator, which is funded by NIH K01 grant on weaving clinical expertise in online health communities. This project was brought about when I was doing my PhD thesis in Michigan, Ann Arbor. I was observing diabetes patient support groups that were held monthly, and this is the moderator, the one on the right. She's a nurse, and she facilitates the support group where she enters her clinical expertise when necessary, while really encouraging the patients to share their experiences. And so the benefit that the patients get from this group is that they not only gain other patients' experiences and their expertise, but also clinicians' clinical expertise, and able to look at both aspects. When you go online, that sort of exchange is lost because it's clinicians just don't have time to look at hundreds of posts, and the online health communities that people engage in, they're not linked with their providers, and so they can't really, the medical or the clinicians cannot really give them the kinds of consultations that the moderator in face-to-face diabetes patient support groups can give. And so I went ahead and studied further how prevalent is it that patients are getting clinicians' perspective from these online health communities. I looked into all kinds of online health communities that are popular and how many of them actually had health professional staff as part of their board, or at least some kind of engagement with their website. And only 16% had it. And 1 out of the 5 websites that had health professionals in their staff of that website, only one had those health professionals actually directly engaging with the patients in online health communities. And so that type of, the kinds of interactions and exchanges that I observed from the face-to-face support groups is largely lost in online environment. And so the idea of this project was to make that happen, augment that sort of dynamic happen in online settings as well. And so one idea is to automatically detect where patients are asking for some kind of clinical expertise, and have that clinical expertise be weaved into their peer patient conversations, just like the face-to-face support group is supporting. So I'm going to talk about how I attempted to solve that problem and get to that sort of idea, what I found along the way. And so I'm going to talk about the social, technical, and biomedical aspect of that project and how I approach the problem. So let me first talk about the social aspect of it. So in order to understand patient social worlds in online health communities, I need to first understand that, because I'm basically developing additional technology in that context. So I need to first understand what the patient's information needs are. Why do they even go online and look for these kinds of information? What are the kinds of information that they seek for? What are their relationships with other patients, and how does that influence the kinds of information that they gather? What are their relationships with moderators in online communities, if there are any? And if the moderators are health professionals versus staff moderators, what sort of exchange are they having in online? So these are the works that came out of the looking at the social aspect of this project, and I'm going to walk through a few of them. So the primary research questions that I'm going to talk about in the next few slides is how do moderators and patients interact in online health communities, and how should moderators interact with patients? So one idea of Informatiator is to have some kind of semi-automated agent or some kind of information entity to intervene in peer-patient conversation, and that's sort of overlapping with the role of moderators. And so I wanted to understand, how should that entity be? How should that agent be with the patients in online health communities? So to study that, I went to that one website that actually had health professional moderators engaging in peer-patient conversations, and that was WebMD. And so WebMD has about 55 online health communities with different diseases. So they have breast cancer, prostate cancer, diabetes, heart disease, and all sorts of diseases, and each of them has their own online health communities. So I wanted to look into them and understand the dynamics there. So the way I did it was, I don't know if anyone is familiar with this, but you could look at the source code, and also on the bottom right, there are these objects. So you could use JSoup or other kinds of script language to extract certain part of the website. So for instance, if I want to get the weight loss over there, that's the title of this particular thread, I could look for what in the source code that actually included the weight loss as the title. And so I can find the tag that is handling the weight loss, and then I find the name of that tag, and then extract that the content of that tag that I'm looking for. And so I built that script and downloaded it to my MySQL database to a local computer. So I'm assuming at this point some of you might have questions around IRB. So this is considered public observation because the WebMD online health communities, the message boards, are open to public, and you don't need to log in to post. If you want to actually post with a consistent ID, obviously you do have to register, but you can still post without any username, and you'll be posted anonymously. And so IRB consider this as unregulated by the IRB because it's considered as public observation. So I didn't need IRB to download the data. So once I got that, I was able to query them and randomly sample the threads, analyze the number of posts being posted over time, and so forth. And so for getting to those research questions of understanding people's dynamics among patients and with the moderators, we conducted content analysis of randomly selected 240 posts. And we also looked into a specific case of posts called See You Doctor posts, and I'm going to get to it further later. And then also performed quantitative analyses of posting activities of these WebMD communities to understand some of the dynamics that I wanted to understand before getting into designing InfoMediator. So results. I'm not going to get into too much details here regarding time, but what did I find about patients' information needs? What do patients ask? So there were several popular themes there. So the darkness refers to how prevalent those questions were, and it was varying a bit by the communities, but in general, patients asked a lot of questions that can really benefit from clinical expertise and also community expertise, as I found from my field studies where they were kind of asking questions that patients can answer, such as which insurance program is better for purchasing this type of insulin, or what where do I get the where can I get the sort of the food that you're looking for, which grocery has better deal, and those kinds of things. You don't need a doctor to answer, right? It's something that really patients can share with one another. Whereas if you're asking for specifically what is the gold standard HbA1c I should be in, because it's differing across different doctors, and also ADA says something different. And so for those kinds of technical questions, you really want to get answers from clinicians. And so I was seeing a lot of those too, wanting to get clinical expertise and also community expertise. And when you look into ADHD, there was more proportion of people asking for that sort of community expertise as parents of kids with ADHD, whereas heart disease was primarily something that can really benefit from clinical expertise. There were some questions around building rapport where they weren't really interested in gaining information, but they really just wanted to be there and socialize. So when I broke down the responses from the moderators, and I also broke down the moderators into staff moderators who don't have health professional background and health professional moderators who actually were brought into WebMD to generate some clinical expertise. And also kind of give you the context of this, staff moderators were paid by WebMD. They're no longer there, and that's another study that I'll discuss a bit later. But the staff moderators are paid, and they're supposed to moderate conversations, make sure that there are no trolling replies and so forth. Health professional moderators are obviously there to help out with some of the medical aspects of the conversations. And so on the left, you can see some of the common themes that moderators were responding to, and both staff and health professional moderators were providing clinical expertise to the online health community members. And there were some differences where staff moderators were actually providing more generic clinical expertise, such as providing links to other websites or pointing them out to a blog article of a health professional, whereas health professional moderators were actually giving just really concentrated clinical expertise. There are some interesting observations here according to different the disease communities. So, for instance, the pain community had quite a bit of moderating going on, which shows some of the reflections of how staff moderators had to sort of moderate conversations so that patients don't really talk about too much about which medications are better and so forth, which is kind of dangerous conversations to have. And there were a lot of sort of pushing back and forth of how patients were saying, well, I want more of this pain medication and my doctors are not giving it to me. And so that sort of reflected the real life experiences and the sort of pushing or the conflict that might occur between patients and doctors in pain management area. And then heart disease had interesting increased proportion of conversations about talk to your doctor, and also in pain as well, where the moderators say, let me get into that in further detail. An example of that talk to your doctor is that moderators say, well, you can't really talk about this online. You have to go see your doctor to talk about this. And so that sort of pushing back from the moderator was an interesting case that I wanted to study, because it might create some resistance from the members, because the very reason that they came over here was because they might have already seen the doctor, or that they talked to the doctor and they wanted a third opinion, or they might have came here for some reason, the very reason, and they might already know that they should be talking to their doctor. And so I wanted to see further how this was an influence to the community, this type of response of, I can't help you here, go see your doctor to solve your problem. What I found was that compared to the generic moderators' responses to patients' questions, when moderators said, go see your doctor, that actually had significantly high number of threads that were actually, the conversation was stopped after that. So there were no more replies, or that the person who asked the question didn't come back. So that sort of incidence of thread length was, the thread length being short was much higher in the go see your doctor threads, meaning that we really have to frame it differently, and there might be some other needs that are not met when patients actually come to online health communities and ask questions that might require their providers to answer. And so when we looked at it qualitatively, the patients were frustrated because they actually had their own objective in coming to online health community instead of going to the providers. A lot of them actually talked to their doctors already. They might have wanted third person's point of view from the online health community. They wanted to compare different doctors' perspectives also to get more of an objective opinion. So they were kind of distinguished of knowledge that are coming out of online health communities versus their own clinical care. And other community members were actually kind of intervening and trying to help with their communication with the providers. The question askers, how they can improve their communication with their providers so that they can get the information that they need. And this type of community members' responses reduced significantly when the moderators were saying, go see your doctor type of post. So that is something that's to be learned as part of designing InfoMediator. And we looked closer into then what's the role of moderators and how should they be exchanging information and opinions with the patients in online health communities. We found out that the staff moderators stopped moderating WebMD in sometime in 2013. So this is actually, I think it was the end of 2000. January of 2013 is when they stopped. They no longer participated. And so we looked at the overall posting activities of members over time and overall posting activities of staff members over time. And obviously that they stopped after they were a certain period of time. And then health professional moderators continued to kind of post afterwards. But this was the reason for why they stopped is still unknown because WebMD never really published about it, and patients kind of started talking about why are they missing and why are they gone, and so that was a great opportunity for us to go in and really understand what were the perceptions of the the WebMD members about moderators and what do they want from the moderators. Are they sad that they left or are they glad that they left because they had these see your doctor posts and so forth. So there were quite a bit of conversations around moderators right around that time when staff moderators left. To understand that, we used certain keywords, mods. That's the word that members use to talk about moderators. So we use those as well as moderators as keyword queries into the MySQL database that we had with the WebMD communities. And we retrieved, as a result, 821 members' posts that contained the word mods, and 166 open codes were generated after we've conducted the qualitative analysis. And the short results shows that shortly, I mean, this is published in JMIR about a month ago, so you can take a closer look at it if you are interested. So the members felt that moderators played critical roles by making the community vibrant and healthy, and they've actually found solutions to problems, and they gave medical information that are helpful for them. They've even felt personally attached to these moderators, expressing that they would actually leave the community our follow-up studies to see if they actually left after they said that they want to leave. And then they also felt that sometimes they're not helpful or even harmful to peer interactions, which is kind of the reflection of what we saw from the See Your Doctor threads. So what's the lesson? What are the lessons that we learned from looking at the social aspects of online health communities? That we can actually use automated systems to help patients get low-hanging fruit at clinical expertise, and use community members to enhance doctor-patient communication. And so it's not just about, okay, let's mute everyone else and just kind of bring in this clinical agent, but really facilitating both other members' conversations and also adding appropriate clinical expertise. And cautiously use how we frame these messages, because that can really kill the community dynamic. And then we need to also develop disease-dependent norms in weaving clinical expertise, because as you saw from pain versus ADHD versus heart disease versus diabetes, they all have their own social norms because of the kinds of problems that they're dealing with. It could be more acute, like in heart disease situation, or it's more chronic, and you kind of have to involve more day-to-day conversations around diet and recipes and so forth. And so they have all these different norms that we need to consider when weaving clinical expertise and developing the infomediator. So I'm going to get into the technical aspect of this project. Does anyone have any questions so far that they have kind of lingering questions that? Okay, so I'm going to get back to my technical part of this project. So then if you're talking about developing this agent, we need to first think about how can we automatically identify when patients ask for something that can actually benefit from clinicians and clinical expertise, and what kinds of question types are there so that we can provide the appropriate information to those question types. And then how do we retrieve related clinical expertise? Is it going to be published literature? What sort of sites should we include in the pool that's validated so that we can do site-specific search results? So I'm going to get to more of the first part of this. And we have several work that's being submitted and published from this aspect of the project. So now I'm going to begin with how can we identify when clinical expertise is needed, and without manual annotation, meaning that a lot of these classification, automated classification tasks require manual annotation for the machine to be trained in generating predictions. But I wanted to see if there were any ways that we can train the machine without any manual annotation, because that's a lot of work and time and effort. So one idea was to download or group all the questions that into two groups. So one group is the ones that were actually moderated, meaning that the questions that were responded by the moderators, and the other group of questions it contains the questions that were not moderated. So the assumption here is that if moderators responded to that question, there must have been something about that question that made the moderator to selectively respond to, because there are many hundreds of questions that are being posted, and moderators only have limited amount of time, and so they have to select questions that are pretty critical. So I wanted to identify what that is using automated classifier. So this is the process of that classification task, where the moderator class meaning any posts that were responded by either staff or health professional moderators. An unmoderated class, which is the posts that were not moderated, were not responded by other moderators. And you can see the sort of the skewing of the two, the size of the two groups. So we had to use different balancing techniques, either oversampling or undersampling to match and balance the size of the two classes. And so I'm going to walk through this process of the classification task. So we first began with WebMD Diabetes Forum data, and we extracted from the questions that members asked on this community the word unigrams, meaning frequency of words that occur in each post, sentiment, meaning how sad or happy is this post, and it's been validated by psycholinguistics literature, the tool that we were using, and the length of the thread, which was an indicator in our prior work about some of the attention that they seek from moderators. And then we use those information for each post as a training data for naive-based classifier, which is one of the most simple classifiers that are actually known to be performing well in text classification. And then we perform tenfold cross-validation to evaluate the performance, meaning that the training data we were using, or the data that we had, the two classes that I mentioned here as part of the data, they were randomly grouped into 10 folds, and each fold will become a test class or test fold, and one fold will be a test fold, and then the rest of the 9 fold will be training folds. And then you kind of rotate that throughout each fold while calculating the performance of each iteration. And so you end up having 10 performance metrics, and then you average them out to generate more generalized evaluation than just kind of placing it on just one fold. So this is the result that we saw. So the x-axis is different feature selection methods. So because there are so many features involved, we perform various chi-statistics to select the most critical ones, but how many critical ones should we include? Those are explored, and according to different features that we use, this is the variations of performance we observed. And the best performing classifier was the F1 score of having around 0.6, which is very low for a lot of the NLP-related classification tasks using clinical notes, because they're trained by manual annotation, and this is purely not manually annotated. And also this is very informal text where people use a lot of language that are not structured, very unstructured, because it's social media data. And so a lot of the social media NLP tasks show about 0.8 as a pretty decent performing result compared to those used in clinical notes, which is kind of around 0.9 or even further out, like 0.95. And so the uniqueness and strength of this paper is, however, is that it was our first attempt to look into social media and patients' social media to see if we can classify their questions. And there's a lot of performance, the lacking performance that could be improved, but this sort of intention to use not using any manual annotation and using social media data to classify patients' posts was considered contribution, and we received a paper award from the Medical Informatics International Association of Medical Informatics. This is published in Journal of Biomedical Informatics back in 2013. 2013. So this is sort of the summary of that, where it was the first study to examine classifying patient posts in online health communities, and it's a low cost. We showed how different feature selection methods and balancing can change performance, and we need to look into further, okay, we weren't doing the manual annotation, so that sort of included a lot of noise where health professionals were building rapport with patients rather than responding with clinical expertise, which is sort of the assumption we had in building this training data. And there might be some legal problems in medical consultation at WebMD, and that's why health professionals might not have responded to posts that actually need their responses. And so our next step naturally was to look at how can we improve the performance as we use the manually annotated data. So we further added some features of subgroups of UMLS and also bigrams and trigrams, meaning not just one word unigram, but 2 words and the counts of 2 words and 3 words in the post as features. And we also added other classification algorithms to compare if the performance can be improved. And we also used other feature selection methods to compare the performance. So to generate the manual annotation, this is the process, this iterative process we went through to sort of modify the code book, optimize the code book, and test out on certain specific subgroup of sample of the data and then generalize it. We also annotated another diabetes community to see how much our model that we generated from this WebMD can actually generalize. So we found after we annotated total of 28,000 sentences, the performance, and made it into a training data, the performance actually increased greatly, where the F1 score was 0.87, and for the question of whether the sentence is a question or not was 0.88 F1 score. And in terms of classifying question types, we looked into fact, value, and policy. What that means is that these were the question types that we derived from a group theory, looking at what kinds of questions people ask in small groups. And so they talked about how fact is asking for factual questions, such as what HbA1c level should I be on, or value is asking for other people's opinion, and policy is asking for action items. So what should I do when I found out that my blood sugar is this high? And so when we attempted to train the model based on these 3 different question types, we found that the fact and value questions are pretty easy. It has pretty high performance compared to policy question types, and so we need more work to get done for the policy question types. So let me kind of dissect a little bit more what this F1 score of 0.87 means. So F1 score of 0.87 that we derived from our classification model was the harmonic mean between recall and precision. And so recall was 0.92 and precision, actually it's not harmonic mean, but there's a certain calculation of F1 score out of recall and precision. The recall that we gained from this particular best performing model was 0.92 and precision was 0.82. What does that mean in the context of online health community posts? So if we were to have 100 patient posts that need clinical expertise, recall of 0.92 means that we were able to retrieve 92 of those posts that need moderators or clinical expertise. For precision of 0.82, what that means is that we got 112 posts predicted as needing clinical expertise, and 20 posts among these were predicted incorrectly. So if we want to think about the effort of moderators moderating online after the classification has been done, you can say that, okay, they wasted their time on looking at the 20 posts because it was incorrectly classified. But it's better than looking at all hundreds of posts and finally finding 109 or 80 some posts were actually something that they needed help with. And so this is increasing the sort of the efficiency of moderators engaging, and it will help moderators to really focus their efforts on the posts that really need their help. So the next step is not just using machines, but also using crowd and even the other members in the community to help out with training the classifier and some other NLP techniques to improve the performance in classification. So the lessons learned is that the existing online health community posts can help us training data for detecting when patients need moderators' attention. And we found a pretty simple method to detect clinical related posts and the major question types, but there's some more work to be done. Now then, given that we can solve this, we have some ideas for how to solve a technical problem. We also need to look at the design aspect of it. What is the interface that patients are going to see? What sort of information they want, and how should it be conveyed? Is it going to be an agent, or is it going to be just a reply? If it's a reply, how should the message be framed, and so forth? And so my student, as part of her thesis, she's looking into, she's conducting participatory design with the patients to make a patient-centered design instead of us designing something and imposing it on the end users. And once we have that design done, we will be prototyping this info mediator that we can further test in the context of biomedical research. So now we have that social and technical aspect of the project. Now I'm going to talk about how we are going to evaluate this technology if it is once it's implemented. And so the outcomes that I'm interested in evaluating is self-efficacy. How confident are they that they can empower, how confident are they that they can actually manage diabetes, actual improvement of self-management and care. And then secondary outcomes are the quality of life and the stress and the amount of social support that they feel they've received. Pilot results of hemoglobin A1C levels. I left it at pilot results because it was a limited funding for only 4 weeks of study. So that wouldn't be enough time to actually change one's HbA1c. And so we left it as pilot results that we can test once these the study's done and we have some pilot work, and we can test this on a longer intervention. So we're just collecting actually more of a risk factors such as their weight and other kinds of clinical outcomes in their clinical settings, diabetes patients. And this is actually ongoing. We haven't finished designing the prototype, but we are actually testing the efficacy between online health community posts and online health community posts with clinical expertise added. And so we're not testing the design aspect of it, but the idea of adding clinical expertise and the framing of clinical expertise that's being added. So it's using the sort of the prototype rather than the actual infomediator as pilot work. So this is a 4-week intervention, and there will be a 6-week follow-up on the outcomes. So the Q1, Q2, Q3 refers to the primary, secondary, and the pilot results. And so we're assessing that in the beginning, 0 week, and then 4th week. And then we're observing the Q1, the primary outcome, in the middle of the intervention. And then we're going to assess those outcomes again at 6-week follow-up. And we're going to, along the way, we're going to have diary, so we can get some qualitative responses of the patients regarding this whole idea of the infomediator. So the specific information that they're getting is actually every week, or actually every 2 days, they're receiving randomly selected online health community threads, just one thread, and they're responding to some of the questions like how useful do you just feel that the thread was. And we're using the instrument validated from information science regarding measuring trust and perceived usefulness of that information, so that we can see depending on how useful they felt about these threads, that actually improve the outcomes in terms of self-efficacy, and how that result was different for the test groups who received added clinical expertise in the peer-patient conversation threads. And in terms of the clinical expertise we actually used a real clinician instead of getting information from the website. So a nurse practitioner responded to each thread, and we used that post as the clinical expertise that we're testing. This is an ongoing trial, so I might have an opportunity to tell you what the results are once it's over. So then the lesson will be how much this infomediator can improve self-efficacy of patients with diabetes, leading to better management of diabetes. So my goal in research is to ensure, coming from the human-computer interaction background, how can we not just end at the social and technical iteration of the project, but also how can we sort of evaluate this in terms of biomedical outcomes? What is the meaning of using this technology? What sort of help can we provide back to the society when it's given and distributed to the end users? What effect can it have in a health domain? So that would be my goal in research, coming from an HCI with a health informatics background. These are some of my other projects that are ongoing, and so I just received a large grant from NSF Smart and Connected Health in preventing child obesity through visualizing family routine data that are collected through acoustic sensing. And we're basically, this running dog is a representation of how well the child did in terms of sleeping and TV viewing and how often the family was having dinner together. And this information will be shared among families that we are matching as appropriate according to behavioral change theory. And so there's also that sort of social exchange going on among the families. And so this is going to be a 4-year project that just began. I'm also working on another mobile health project to show these patients who are at risk for diabetes and heart disease, how their day-to-day activities, including food, is going to impact their risk in 10 years of about CVD risk. So we're showing the real-time updates of the risk change according to the kinds of diet choices that they make. And this is funded by an internal grant at Michigan State University, which was the institution that I was in before coming to UCSD. And then also looking at patient-generated videos as health intervention, and this is something that was just brought up by our Jacobs Medical Center, and I'm looking forward to engaging further in that project. So thank you so much for staying with me in working through my project, and these are the people who've contributed to the project. So thank you. Please, if you have any questions, feel free to email me, or you could ask now, and we still have some time. Oops, I didn't see any of the, okay, could the performance be due to the fact that moderators missed posts that could have used medical? Exactly, yes. Okay, yeah, sorry, I didn't get that. I didn't read the chat.
Are there any more questions? Okay, well, thank you so much, Jina, for your presentation. Thank you, everyone, for attending this webinar. The next webinar will be in the month of December. We're not going to have any in the month of November. Thank you, everyone.